we're going to get started. By delay, technical difficulties. Hopefully, we can get the computer to accept the DVD. So it's a pleasure to introduce Dr. Craig Klugman. He's a Reuter Professor of Medical Humanities and Assistant Director for Ethics Education at UTHSCSA. And Dr. Klugman is going to talk about advanced directives, the film, and the reality. So hopefully we can get the film going.
Thank you. I appreciate you all allowing me to come here today and subject you to the film. But hopefully we'll get that going. So there's actually been a lot published. There was an article in The New Yorker last week. I don't know if anybody caught it. Did you catch it? Okay. And it's a great article. It's long, but it's really quite wonderful. And a large part of the article talks about this study that was published in 2008, which showed that it's a Togawande, and essentially he's saying that we need to have end-of-life conversations. That this is a hard thing. It's weird to turn and see yourself. It's the hardest thing for docs to do is to say to patients, there's nothing more that we can do for you, or what we can do for you is experimental. I mean, there's always something we can do, but the question is whether it's actually helpful to you, the patient, whether it will improve your life or not. And a lot of times we get people, and he's talking specifically about cancer patients, that we can always keep you going. We can put you on a feeding tube. We can put you on a ventilator. We can give you another clinical trial, and another clinical trial, and another clinical trial. But at what point do we sit down with our patients and go, you're not going to get better. We can keep you going maybe an extra month or two, but the quality of that time probably isn't going to be as good. The side effects of these medications are pretty severe or unknown. And so he talks about that we need to learn to be comfortable ourselves with telling our patients, you are going to die. We can help prolong your life in a little way. We can make your life a little more comfortable. And he suggests we do it in several ways. One is we ask patients, what are your goals for the time that you have left? So rather than making the assumption that people want to keep going, that we should have these realistic things. And his idea comes out of this 2008 article, which said that which shows that when you have conversations with patients about advanced care planning, that they tend to have less aggressive care. Often that costs less, often 80% less than their care would pay if they went aggressive. And I know we don't like to mix medicine and business, but it's the new reality. We have to talk about money and resources. That they take less aggressive care, they have higher quality of life, and any of you who have worked with hospice know that to be true, and that their families have a much easier grieving process. So they deal with it better. They're unlikely to have deep depression. They're unlikely to have abnormal grieving. So doesn't that sort of data behoove us and sort of tell us that we need to be having these conversations more? And he talks specifically about dealing with these conversations with patients who have terminal illnesses. He was actually a surgeon on this one cancer case, and after the 4th round of chemo, with each round seemed to release more and more mets into the body. It was a lung cancer, non-small cell, from a woman who had no history of smoking. And, finally it was like to talk to the family about it, and then they went on a 4th round of chemo with a phase 1 trial, and it was just, he said, why are we doing this? And the family, it was a young woman who had just given birth to her baby. She found out the week before she gave birth. So there were all these challenges, but once he was able to talk to her and the family and say, hey, you know what? You're not going to get better. What do you want to do with your time left? They actually were more accepting, and they decided not to go for the aggressive treatment and just to have the meaningful time with her. So you really should take a look at the article. It's really quite well done. Well, so I've been teaching and doing advanced care planning for a number of years now, and it seems like the message doesn't get through, at least to the medical students, about how to do it and how to do it well. So one of the tools that I have developed, and I'm going to pass out information about this, so feel free to take one or take many, is called texaslivingwill.org. And this is a program that is free, and it's created by our center. We made it with a grant from AT&T. And it is something that you can use and your patients can use. And what it does is it provides educational information. So there's information written by lawyers and written by attorneys, and it's all translated into English. And then it has an interview component. So it's like doing tax software. Nobody likes doing their taxes. But you can use these programs like TaxCut and TurboTax that provide interviews that make it a little easier to do. Well, our program does the same thing. So you can go in and it asks you, you know, what sorts of things you do or do not want at the end of life. Do you want CPR? Do you want respiratory support? Do you want blood products? Do you want dialysis? Do you want antibiotics? All these sorts of issues. Yeah, please you might want to take more at the end. Feel free to. So, and at the end of this, and it also allows you to state who your medical power of attorneys are. And at the end, you get to print it out in this PDF, which can then be literally printed out, and you can sign it, have it witnessed or notarized, and then you have your legal advance directive. But it makes it really easy. 70% of people get advance directives from their attorneys. We know that. And most people can't find them when they actually need them. So the program also allows you to put in your driver's license number. And if you choose to do that, then it is a publicly available part of the website that anybody can go in, put in a driver's license number, if they know it, and pull up that person's advance directive. At the moment, that is unsigned, so it's not legal, but at least it'll tell you who the power of attorney is and what their goals and desires are. And we are actually working, within 2 months, we will have electronic signature on this, so that it will be a legal signed document. The state passed that law last year, electronic advance directives. You may have seen it, the new out-of-hospital DNR orders that went online about 2 weeks ago. But so the Texas Department of State Health Services put a new out-of-hospital DNR on their website. It's an electronic signature now, so you can do the electronic signature and then print it out.
So how do you search that? You just search by?
So you can actually go to our website and go under forms, and the link is right
And the
there.
new out-of-hospitals in there?
Yeah.
So, Craig, does that stay up there on a server that other people can search to find out whether or
I
not?
don't
there's a
think they
record?
save it. It doesn't.
There'll be all kinds of issues related to that. I imagine.
Yeah.
And
Well, it is and it isn't, because it's not private health information.
On the old one, there were like 3 or 4 different signatures, so you all have to do it together, or can it?
Yeah, it's all at one time.
So it's sort of impractical for a hospital setting.
What you can do is save the PDF to a hard drive and then file it that way, but there's really no storage capacity with this.
So that's best for folks at home that you have all.
Right, except that it still requires the doctor's signature.
Yeah, so I was going to say, if you have a visiting hospice physician that can do it on your home computer or something.
Right. It's kind of limited how helpful that will be. I think for the advanced directive, since we have storage capacity, it'll be very helpful. Storage can be really interesting. As you probably note on this, we have an iPhone application. So you can actually download, if you go to your app store on the iPhone and go TLW, Texas Living Will, you will actually be able to download this free application. So you can actually do this with your patients on your iPhone.
They might be ready.
And it sounds like we have the movie ready, so we'll talk more about this afterwards.
Please sign in.
Trying to get the vol-
Stop it! Why do you always do this? The doctor wants to keep her alive, so there must be some chance that she's going to wake up.
Kathy, wake up with what kind of life? Pent up in a feather like a houseplant? No, Kathy, not my daughter.
I will never forgive you. I never will speak to you again. I hate you.
Thanks. The rest of your life may not mean living until your 90s. In fact, for people under the age of 45, their greatest risk of dying is from violent means. That means motor vehicle accidents, suicide, and murder. The three major cases of bioethics that established end of life in the United States, Karen Ann Quinlan, Nancy Cruzan, Terry Schiavo. What did they have in common? They were all young women in their 20s.
Oh, you can help me with Dr. B's exam?
Yeah, you should pay attention to this. It's the kind of thing we had to go through when me and Willow died. I'm going to sign up for this Texas Living Well thing.
To create an advanced directive, your patient needs to be competent and capacitated. The time to have these discussions is when a patient is healthy and has come to your office for a regular checkup, not when they're being wheeled into the emergency room on a gurney. Now, to create an advanced directive, your patient needs to be competent and capacitated. However, when you go to the advanced directive, you don't need to be out of there. You don't need to have any consent voucher whatsoever.
Oh, seriously?
Next slide. An advanced directive is a gift to your family. I can't tell you how many times I've seen a family torn apart because nobody knew what the patient wanted. The documents are important, but the conversation is even more critical. Next slide.
Nick, we're too young to be thinking about stuff like that. Besides, we'll probably never be in a situation like that anyway.
My pulse during that class. I think I might just right to my chances of becoming a doctor.
Well, if you fail as a surgeon, you can always fall back on stand-up comedy.
Hey, what did you guys think of that living will speech last week?
Hey, Dr. Dead? That's for old people. Geriatric stuff.
Actually, I already signed up online. Yeah, I mean, I had a really good conversation with my family and everything.
You did? You don't get extra credit for that, stupid.
Yeah, I know. I thought about my mom while in that. Like, if something were to happen to me, there was no chance of me waking up, then, I mean, how could I burden them like that?
Social Security covers long-term health care.
Yeah, but it doesn't cover my mom hoping I'll wake up someday. You know, or my dad having to change my diapers.
He already wears diapers.
I mean, if I was brain dead, let me go, you know? That's just how I feel. I just can't believe someone like my doctor has never even brought this up before. I mean, honestly, wouldn't you want to talk to your doctor about it at some point?
It doesn't matter what you want. It's a waste of time. Besides, I trust my family will do the right thing. And it's bad karma to write down how you want to die. It makes it come true.
Ooh, makes it come true.
All I know is that I'm going to talk to my patients about end of life. I mean, I know we're not supposed to talk about this whole worst case stuff, but it's better to talk about it than not to, right?
Talking about it gives me the creeps. God, Nick. Why so gloom and doom with this advanced directives thing?
Laura, I just think it's important.
Hillary? Let's talk about good things, like me saying thanks for you getting me through exams. My dad's working late tonight, and he gave me 2 tickets for tonight's game.
Oh, sounds like a great first date to me.
I got a new outfit.
Thank you. We're going to be talking about this for the rest of our lives.
Charlie, this is Unit 2. Go ahead, 2. Charlie, we have an out to your location with a passenger from a two-vehicle bus with heavy traffic.
Unit 2, you're en route to the stadium.
Roger that.
We received the driver, and we have a truck that's pulling before you on the pass.
Ladies and gentlemen, a 21-year-old male was a restrained passenger in a vehicle obstructing the driver's side. Was in traffic approximately 20 minutes. minutes prior to EMS arrival. Patient has been showing some signs of increasing radial pressure during flight. Patient has a depressor, looking at depressor fracture of the left temporal region. It's only visible trauma. It's intubated by EMS on scene, 7.5 intratracheal, 23 centimeters of the teeth. File of IVs, RPs, and questions from us.
No, we got it from here. Thank you very much. Mr. and Mrs. Castillo, I'm so sorry. We did our best.
You did your best, Doctor.
That don't seem good enough. They're never going to hear their son's voice again? Flip of a switch, and he dies. We did our best.
We did our best. As you know, she was involved in a terrible motor vehicle accident, sustained a horrible closed head injury, and had a severe cerebral. It's too early to tell how bad things are going to be. But right now she's stable on a respirator, hemodynamics so fine. But the initial test and scan showed that she has quite significant CNS injury.
Is she going to live? She's not brain dead, is she? Well, what are you going to do?
You know, it's just, it's too early to tell, but I'm pretty confident that she has so much damage that she's not likely to be normal.
Well, when can we see her?
I'm so sorry.
I just can't do this. She's my baby. Daddy, she's not dead. You know, she could wake up, right? I mean, miracles do happen.
So when, Jenny? When do we decide? Is she going to lay here and rot away here for months, years, like the Terry Shivo woman? Is that what you want?
Mr. Stevens, are Laura's wishes written down anywhere?
Dad, she wouldn't want this.
Shut up, Dylan. Would you listen to the plug on you? Don't you ever say that. And you're gonna have to live with the fact that you killed her. I mean, she wants to fight. You have to protect her. How can you even think about letting her die?
You trust your little Nikki, right? So smart. First to graduate high school. Gonna be a doctor. He was clear, Mama. He didn't want this. He was a good boy. Even though he demanded that his mom and me wouldn't let him stay hooked up to all these things. He even made me talk about it, remember? I said, you keep me hooked up to a car battery, keep me alive. And he just laughed. Because he knew he wouldn't put any of us through all this.
My father almost hit him with the shoe, and he showed him that paperwork. God will take you when he takes you, your papa said. But I never thought this would happen. He's so young.
You heard what Dr. Lang said. You were there for the conversation, Jenny. She's gone. I know she's just suffering there with the tubes and drugs keeping her body alive. They've got her strapped down like an animal.
Stand to see her this way, Carl. But I just can't let my baby go.
Mr. Stevens, she is an adult, and legally, unless I have definitive proof of what Laura wants, then she will remain on life support for either an extended period of time, or she may die quickly. I don't know. But I do know this. I believe that God has given me the ability to keep her alive, and the state has given me the authority to do so.
She didn't say what she wants. But Dad, you know she wouldn't want this. What if she's okay?
She doesn't want to die, Dylan. Dead.
No, enough for both of you. She's my daughter, and I won't sit by and watch her hooked up with all these machines. Either you remove that tube, or I'll stand on top of her and yank it up myself.
Carl, stop it! Why do you always do this? The doctor wants to keep her alive, so there must be some chance that she's going to wake up.
Kathy, wake up. What kind of life? Pent up in a bedroom like a house plant? No, Kathy, not my daughter.
I will never forgive you. I never want to speak to you again. I hate you.
¿Es eso what you want? ¿Tú eres el hombre de la casa?
No, Mama. You became a man when you made that decision. Doctor, you are a good woman. You are a good doctor. This time, let it be with God. Thank you.
So the problem with watching a movie with the producers, you have to watch all the credits. Comments, thoughts?
So why did you choose relatively young people with a traumatic injury rather than older people with medical illness?
Because it's really geared towards teaching students, and they think that this is something that only happens to older people. And among the seniors, there's a higher rate of completion than there is with young people. And we felt that if we could get young people to connect with the people in the film, that they would be more likely to do this for themselves and talk about it with their patients. So it was really kind of reaching the demographic that we were going after. And it was a traumatic injury for the simple reason that that's what they're most likely to die of at that age group. Yeah.
Respond to a couple of things you said earlier.
Sure.
About people being on phase 1 studies for cancer treatment. So there is across the board about a 5% response rate. And if you're dying and you have a 1 in 20 chance of getting some response, which may be in a few weeks, or it may be dramatic. If you were the first woman with breast cancer to get Taxol, that was amazing. Or if you were the first person to get Klugman. So I don't know that people go on to those phase 1 studies with hopes that they're going to be cured. There may be some more altruism in terms of testing out drugs. So there is a rationale for doing that. Maybe it gets to a point if a person's on their second or third phase 1 study and they're not responding, that you might want to pull back. And then I once heard a presentation from an AIDS survivor who got sick in the 1980s before there was anything, and who was a real advocate for people being able to try experimental treatment even before it had been tested, and believes that and I was hearing him talk 20 to 30 years after his initial diagnosis, making the case for people being able to try risky things in order to stay alive, and going from treatment to treatment to try things out. And for him, it was a matter of survival. And he did make it against long odds. And now it's a commonplace thing for people with HIV disease to survive.
Yeah, actually, it was a big movement in the HIV community that got people greater access to experimental drugs.
And they're fast-track service. Fast-track. Change the process.
Absolutely. Gwande in the article, he gives one case where a person has lived for 10 years because of experimental treatment that they survived, and those numbers, those are rare. They aren't your common. It's we get the same thing with patients in persistent vegetative state, and the family thinks, oh, they're in a coma because somebody used that term, and people come out of comas all the time. It's like, no, you get a 1 in 100,000 shot, but it's about me. We also have really good evidence that there's the therapeutic misconception that people in phase 1 trials, they may claim they're doing it altruistically, but when you really get under why they're doing it, they're hopeful that they're that 1 in 20 persons. I have a colleague who says there's no such thing as false hope, that all hope is useful. It's just a question of whether, there are a few things. One is, are we allowing these people to harm themselves and to have, making their final days and weeks of a lower quality than they could be otherwise, chance to have meaningful interactions with family, and that was the question, what do you want to do with the time you have left? What do you want to accomplish? Are we preventing them, by encouraging these trials, do we prevent them from having that sort of meaningful experience in the end? He talks, in the article one day, talks a lot about the Ars Moriendi, and if you haven't read some of that literature, it's really interesting that during the Middle Ages, there were the greatest fear that most people had in life. Death was normal, people died all the time, but their greatest fear was that death would get to them unaware. And so there were all these books about looking for death signs when you knew that the final moment would come, so that you could assume the position, and that was laying down arms crossed over your chest, and early enough your legs were up in like a triangle. And you would have your friends and family come around, and the priest would have to come around. And it's amazing how many people this was their way of death. But one of the greatest fears of life, that you wouldn't have the signs to be able to do all these things at the end of life. And, you know, we've lost that art. And hospice and palliative care is trying to bring that back. But as you all know, the use rates are very small. By the time people are referred, it's very late. There was an experiment that he talks about it's a very long article, by the way, that he talks about, I think this was New England, where they put people on hospice, but they allowed them to get all the care that they wanted to. That they could go on all the trials they wanted to, have as much aggressive treatment, but they still got the hospice support. And it turned out most didn't show, they'd go a little way, but they didn't choose to go as far as people do when they don't have the hospice support. So there was something about having that network, having that permission to talk about these issues and to do planning, that people chose not on their own with the option to not have as much aggressive treatment and to save a considerable amount of money. The other factor is, I think we can no longer look at health care as, you know, everybody gets what they need or what they want. But it's a very limited resource, and I think the health reform bill really encourages us to look at things this way, that where are we best using our dollars? You know, 17% of our GDP goes towards healthcare, and it's showing no evidence of slowing down. It's the highest in the world, and yet we only have very middle of the road health indicator scores on all levels. So that's part of my encouragement, is that, you know, we're spending so much of our healthcare dollars in these last parts of life to give people this hope, this encouragement to fight, to keep going on, then maybe we need a new narrative when we're talking to people at the end of life. So that's just my response. But you're right. I mean, there are those people that it is helpful to. And who's to say there's not a psychological benefit?
Is there evidence that young people, like in this situation, first of all, how many of those people like that really have advanced directives?
Very, very few.
And if they do, are they followed?
So the data
because
on...
when I read, literally hundreds of advanced directives a year.
Sure.
And they all say if I am terminally ill. And I get all kinds of people in all kinds of conditions, and many of them are not terminally ill. So I do not make these people DNR.
Well, the law for Texas is terminally ill or irreversible condition. So they don't have to have they don't have to have a terminal disease or illness. They can have an irreversible condition.
Yeah,
so
that's hard to interpret for me.
It's hard to interpret for anybody.
Yeah, right.
Yeah, so it says that depends.
Yeah.
That depends.
Sure.
Well, even elderly, Mark, that depends. And so it's up to the person that they have as their medical power of attorney.
Right.
And, they can defer.
So I can tell you that...
I'm taking care of, 3 or 4 people with an brain injury now. They have irreversible condition. They're full code because their surrogate is telling me, I want these people full code.
Right. So
if they had an advanced directive, I guess if I knew they had advanced directive before they had their anoxic event,
right.
I should ethically make them DNR. Is that correct?
Right. So if they have an advanced directive and their surrogate is saying don't follow the advanced directive, you can actually call an ethics consult, and we will work to have a new surrogate appointed. Because
which of course is going to cause all kinds of disruption with my dealing with that surrogate.
It's not pretty, yeah. It will cause a little havoc in your unit.
It's a lot easier to code the patient, and probably a lot more beneficial to all parties concerned.
No, not necessarily. I mean, it's not beneficial to the patient who's not having their autonomy honored.
Right.
If you have knowledge that there is an advanced directive and you do not follow it, it's a misdemeanor in Texas.
Oh, really?
Now, nobody's ever been charged under this, but on the books, it is technically a misdemeanor. If you know of an advanced directive and you follow it, even if the family's telling you to do something else, you are protected from civil and criminal liability. That's the way
it has to be a
law.
duly executed advanced directive.
Has to be properly executed.
By a person that had capacity to execute it at the time.
So a lot of people have a surrogate, but they don't have the directive, in which case all we have is the directive's word. What we would do in ethics consult is we would say, explain to the surrogate, your duty is not to make the choice that you want, it's to make the choice that the patient would want. I can tell you from our data that only 27% of people actually talk to their medical power of attorney about what they want, and only 34% give a copy of the advance directive to the medical power of attorney. And this is among people who complete advance directives. So the rates are extremely low. About 33% ever talk to their doctor about an advance directive. Okay. So the rates are bad. So the studies show that advance directives aren't very good tools. That surrogates, most of the time, do not state what the patient would have wanted. Now the alternative, well, we don't really have an alternative, right? So that's the problem. It's the worst thing out there, but it's better than anything else. So if people have ideas of better ways to do this, and there are a lot of states, I think 34 states now have pulse or post forms. So these are single documents, dual-sided, they're usually bright pink on cardboard stock. And they have the DNR, the out-of-hospital DNR, the medical power of attorney, and the advance directive all in this one form. And the idea is that the form goes with the patient so that you don't have to worry about finding it. It's always with the patient. And so this has been an alternative that has recommended. It started in Oregon where it wasn't made law. It was just an agreement among hospitals, long-term care facilities, and the ambulance service. A lot of states have jumped on it. Texas has not.
For that RSA, person's going from the hospital to the nursing home, it's not buried in all that rest of the
right.
chart.
It's supposed to be
affixed to their arm or something.
It's this bright pink thing that goes in the front of the chart. So supposedly it's easier to find. I don't think I haven't seen any studies on this, on how the efficacious they are. But that is kind of the alternative that's been happening. Hospice programs always recommend to patients that they put their documents in a Ziploc baggie. Used to be on the refrigerator, now it's in the freezer. That's the big thing. Here's the problem. I teach ethics to EMS. They never heard of this. And when I explained that this is what hospices recommend, a number of them, the response I got was, when we are going in to see a patient, we're going through that door directly there. We're not going to stop for a popsicle. So they thought the refrigerator concept was the worst thing they ever heard of. Their recommendation was to put it over the bed, pin it on the patient or on the front door. Because if it's not in their line of sight, they are not going to see it. We use these wallet cards, and that's what these are. And on the back you can see I have an advance directive. Because if you are in that traumatic accident, what they're going to do is grab your wallet, pull out the driver's license, and then there's a big red card that says I have an advance directive. I don't have any data whether that works or not, but that's sort of what we're going on. Our feedback has been quite excellent on this.
So why do doctors don't speak to their patients about advance directives? And doctors are the best group of people that should be doing this?
We know that 70% of people get it from their physicians, and physicians will charge anywhere from $350 to $900 to do an advance directive. Okay, I've priced it around town. That's what they charge. I'm sorry, attorneys. Attorneys. There was actually a part in the healthcare bill where you could get reimbursed for having end-of-life care conversations with patients. But Sarah Palin turned that into death panels, that you were going to be required to decide how you had to die, and so that got nixed out of the final bill. So there is no, you can put it in as conversation with the patients, but there's no advanced directive discussion thing. Why don't doctors should do it? We don't teach this very well to med students. What we teach in the formal and in the informal curriculum is that death is the enemy, and that your job is to save lives. What I like to teach is your job is to treat patients as much as they want to be treated, and you can treat them, but always to provide comfort. I'm just one person at one medical school. And it's just hard. This is a room filled with people that think about these issues, that deal with patients. And how often are you really comfortable having these conversations? And so for people trained in this, it's really hard. For lay people, it's even harder. As Elizabeth Kubler-Ross wrote in the 70s, actually late 60s, we're still a culture that denies death to a large extent.
So I would hope that most geriatricians have this as a regular part of their practice because of the population that we're dealing with. The issue for me is when to have the conversation. Because the timing, it's not something you want to talk about necessarily on the very first visit. You might ask about the presence of directive, but you don't necessarily ask about, well, would you like to sign the GNR order? And there are moments in the process of establishing relationships with people where issues come up where you can sort of open the door, go in there and have a conversation about it and get people to complete the forms. And you have to be willing to deal with ambivalence. And it doesn't have to happen all at once. It may not be a neat, clean thing that happens in one encounter, but it unfolds over a series of encounters before it's actually done.
Right. It is a long conversation. Don't bring it up the day that you give them that they have a terminal illness. It's a terrible time. We have excellent data that shows people, when you say to somebody, you have cancer, you may spend the next 2 hours with them, and the only thing they're going to remember was you have cancer. So it is a conversation. It's not an event. It's like informed consent. It's not a single time thing. It's a long-term conversation. And I wouldn't bring it up that, hey, you have an advance directive or a living will. Like the term hospice, it's kind of gotten this unsavory view that people turned off. It means you're talking about death. So what I recommend to people is that you ask them, have you ever thought about if you were unable to make your own decisions, the kinds of things that you would want? And you can make it humorous. So we actually have a tool on our website to help people to have these end-of-life conversations. And so we say, if you could design the scene, write the play for your last moments of life, what would it be? Who would be there? What would be happening? Would you have music? Would you have poetry read? Would you get foot rubs? Would you want a doctor around? Only 10% of people want a healthcare provider around. Less than 10%. But 85% of people want their pet. Okay? So you can bring these things up in a more lighthearted way. I've also found that there are cultural issues here as well that should be aware of. So Native Americans do not talk about death for, as they said in the movie, because to say it makes it come true. There's a lot of magical thinking that goes on. Mexican culture is also very much this way, that you don't have these conversations. So what I've found is useful is hypotheticals. So you can use like Terry Schiavo right now, most people still know about. So you can say, hey, did you ever, hey, I was just thinking about the Terry Schiavo case the other day. What do you think about that situation? So you can kind of get these conversations sideways. My example is my great aunt who died last summer at the age of 99 and lived on her own until she was 96. When she lived in Florida and she was about 92, we had been having conversations for a long time about advanced directives. And she would not complete one because she wanted to live forever. She wanted everything done. When she was 88, they had found precancerous polyps in her colonoscopy. And she was horrified and wanted them removed immediately. And I said, Aunt Rose, you'll be 110 before this is an issue. And she said, well, I don't want to have to deal with it then. So we as a family disagreed with her choices, but we're very confident about her choice. Well, Terry Schiavo happened, and we were chatting one day. I was visiting her, and she goes, it is awful what they're doing to that woman. It is terrible what they're forcing on her. And I said, Aunt Rose, this is what you've asked for. And her response was, I had no idea it meant that. Send me those documents. So I think a lot of times, because we're not comfortable having a conversation, that we don't ask these simple questions. We assume the problem with the Texas Advance Directive, it says, I want everything, I want nothing. That's what in the statute is. If you go to the Code of Law of Texas, there's an Advance Directive in the statute. We cannot use things like 5 wishes. We cannot use most of the forms that people find online and like to fill out. We have to use legislative language. We're one of 5 states that requires this. If your patient's a VA patient, they actually need to have 2 advance directives, one with the Texas law and one that is the VA document, because the VA has its own specific document.
have a question about that. Am I to understand then if you have a VA advance directive, it's not notarized, it's not valid outside of the VA?
If it doesn't use the language of the Texas one, it's not valid outside of the VA, period, even without the signature. We require 2 witness signatures or a notary, any one or the other. And that's
So
a new law.
Texas requires either 2 witnesses or a notary.
Right, and that's new as of last summer. Before that, it was always 2 witnesses. The notary came in on the last
So
legislative
folks
session.
leave here with the VA advanced directive that has no standing outside of the VA.
It gives an indication, but it
Right.
has no legal standing.
And so the only circumstance where that would really come to play would be where there were two people vying to be the patient spokesperson.
Well, or if they're, picked up in an ambulance, and they're brought
And
to
then the EMS
UH.
bank, we really have to resuscitate them because they couldn't honor that if
Right, well,
they followed it.
well, you couldn't, even with a regular advance directive, you'd have to resuscitate anyway. They need the out-of-hospital DNR for EMS
Right,
not to resuscitate.
right, okay.
But if they're in the OR and they're, stabilized and somebody shows up with the VA advance directive, they may follow it, but legally, they shouldn't,
They shouldn't.
because it doesn't meet the rule of Texas law,
I didn't know that.
which is a challenge.
Are people briefed that when they do their VA?
I don't believe they are.
We probably need to.
It's a challenge.
Project for somebody.
It would be a great fellow project
Yeah.
to work that out.
That is a difficult thing.
Yeah, it is a challenge.
Realize that.
So if they're going to a nursing home and they have a VA advance directive,
They need.
We usually
they
send
need
them with
this.
the out of hospital, the Texas out of hospital. Though.
Right. Now, here's the
So
thing
that
about the
works.
long-term care facilities. They may or may not honor it. You actually have to ask, anytime you send somebody to an LTAC, what is your policy regarding advanced directives and out-of-hospital
Is this an
DNRs?
LTAC or a skilled nursing facility? Those are entirely different things.
For me, I lump them together. I think they both.
Because an LTAC the implication of an LTAC is a person's going to survive and
Oh, okay.
live there.
Well, skilled nursing
And live
facility.
from there. Okay,
Yeah.
skilled nursing.
So they may have policies that say, we call 911 no matter what.
Not most.
A lot of them do, you'd be surprised, because
Not
people
the
don't
nursing
ask.
homes, assisted living
Yeah.
facilities.
Assisted living?
Assisted living.
Because in Florida, we discovered this when we were looking for my aunt, that because after she had her stroke, she needed a skilled living facility.
This is actually, it becomes a liability issue. And they just do not have the staff, especially at nighttime,
Mhm.
if something happens, to cover it. So the easiest thing for them to do, even if it's against the wishes of the person, is to ship them out.
Right.
Which is one of the reasons now why it's misdemeanor, because it's the assisted living centers too that have to follow the directive. If somebody doesn't
Right.
want to be resuscitated or shipped out,
Mhm.
that should be honored.
It should be.
And they should provide, you bring in hospice care, you provide other care in the facility. So,
And Mike, you do a lot more of this than I have, but nursing homes sometimes would rather have the person on hospice, and that sort of protects them.
right, well, they don't, so if you get hospice in, everybody's tension goes away. If they accept hospice, because then it says the person's terminally ill. Now, there may not be a lot of value added by having hospice there, but if it makes the nursing home more comfortable
Right.
and calm, then.
It could be worth doing.
but you can still be full code on hospice.
Yeah.
Mhm.
That's a whole other.
Right, that's another
That's a whole other
conversation.
thing.
The other thing that I find helpful for having this conversation is not to make it just about the DNR and the advanced directive, but to look at it the whole package of end-of-life planning. So I asked them, have you written a letter to your family for them to open and put things in it like, happy memories, lessons of yours that you'd like to pass on, that you forgive them for anything they may have wronged you for, that you ask for forgiveness for any wrong you may have done, whether you're aware of this wrong or not. It might have been some unknown slight. But those sorts of things really help the family with the grieving process. Funeral planning. And there's some really fun stuff to talk about with funeral planning now. So beyond traditional options of being buried or cremated, you can be shot into space. Seriously, there's a company called Celestis, and they'll shoot some of your ashes into space. You could either have the ashes come back down, sort of a short-term trip, or you can go on a long-term space probe. That's the Roddenberrys are on a long-term space probe. You can be buried in a coral reef. They put ashes into a concrete cast, drop it in the ocean, and then coral reefs grow around it. That's become quite popular. You could choose sky burial, which is a Tibetan thing where you chop the body up and let vultures eat it. Very green. There's a Tibetan, yeah. There's also green burial now. There's a place outside of Huntsville that does green burials, and it's a beautiful park, nature preserve, and they put the body in the ground, no shroud, no coffin or anything, and there's just a little plaque, and you can get a legend to see who's buried in that place. But it's just a park, so rather than wasting space and taking up space for a cemetery, it's just sort of a natural area, and you become part of that.
Carbon credit for that.
Do you get you can compost yourself. In Sweden, they compost bodies. They soak the body in lye so that all the bones get dissolved, and then they throw you on a compost heap. It takes about 2 weeks for a human body to be composted. So lots of, and some of these you can also be cryogenically frozen. So these are some of them sound really silly, so they're a way to have the conversation but sort of lighten the mood a little bit. Do they have a last will and testament? Have they decided who's going to get what? So I put this in terms of this whole package. So it's not about waiting until their health is taking a decline. It's about saying, I like to keep my records very complete, and I'd like to know where you have these things. We know that 60 to 70% of people who have advance directives keep them with their last will and testament in a locked, safe deposit box. Not a great place to have it, but that's where most people have it. Like I said, only a third give them to their medical power of attorney. About 40% give it to their spouse. And mine is actually on my Facebook page. So I scanned mine in. It's got the signatures and everything. Saved it as JPEG file. Made a little cover. This is my advance directive with the date. And if you are my Facebook friend, you can go to my photo albums and view my advance directive. Here's the neat thing. If you print it out, it's legal because it's considered a copy with the signatures. So there's like 275 people who have access to my advance directive. And it's not PHI, so it doesn't fall under HIPAA. So you can make it really everywhere. I know people keep them on their Blackberries, on there. Glove box, the car. I say you make, and copies are legal, so you don't need to have the original for this. You can make lots of copies and distribute them everywhere. Make sure your doctor has them. I mean, it's so few people who actually give them to their doctor. Or if there's a hospital that, My Healthy Vet, the portal, has a place for them to upload an advance directive, and then you can pull it off the medical record from the other side. So for VA patients, that is definitely the place to have them go. Then they're easily available and accessible. So getting patients to fill them out is one thing. I've had cases where the patient wouldn't fill them out because they felt writing it was the magical thinking thing. It would make it come true. And they actually, and here's the hardest part, is in that case, they have to admit that they're dying. And that's really hard for anybody to do. Really hard. So the hypotheticals, the doing it when they're there for a healthier visit, not when they're there for a sick visit, those are better times to have these conversations. And getting someone who's mid-heart. But in that case, it was social work and ethics, and we talked with the family, and we became very comfortable knowing who the medical power of attorney was and what the patient wanted, just from the conversations. So we noted that in the chart. And we didn't have the advance directive, but we had the conversations that had been documented. And that was actually sufficient for our purposes. So, like I said in the movie, the documents are important. They're very helpful, especially if the power of attorney is not following the patient's wishes. We are then able to intervene and increase the chance of that happening. But it's the conversation that's the really critical stuff. When we can document the conversations, that's 80% of what we need right there.
So theoretically, it's a VA power of attorney from here. You're outside. It can serve as a guide, though, even though if it's not a legal document. You see the mother and the father, they're arguing over what she would have wanted, but you have a power of attorney there that says clearly what she would have wanted. And there's one of the parents saying, this is what she wanted.
It would be helpful if it's signed and notarized. Now, if they don't have one outside of the VA, the state of Texas says it very explicitly who makes the decisions. So it's spouse, majority of adult children who are readily available, so they all have to agree, basically. Then it's parents, then it's nearest living relative, And that's nearest, basically, it's usually defined as who you can get a hold of. And then, if there's nobody on that list, if it is about just any kind of treatment, it's hospital clergy. If it is about life-sustaining treatment, it's 2 physicians, one of whom is not a treating physician. So if you encounter, I just had one of these calls last week because I'm on the consultant on call right now for UH. They called us. And because it's complicated. This is what I do. I know all these little details and nuances. So if you have a case that gets that weird, just call us. Ethics will come, we'll be able to explain it to you. So I don't expect you to know all this, but just know that we do provide that assistance. So it does get complicated. So if the father and the daughter are arguing about it, and there's no directive at all, the father's got the original, father's got the say. Legally, it's him.
And what if it's an out-of-state person? Like, let's say, example, I'm not from Texas. I don't live in Texas.
You still have to follow Texas law.
And I have my own living will.
So we have a friendly state statute. So we will honor advance directive from another state, insofar as the Texas law allows it. So if you're coming here from Oregon and it says, you know, I want physician-assisted suicide, we're not going to do that. But as far as the law, but yes, we will honor from out of state. If the person is residing in Texas, though, they're not just passing through, they should have a Texas one. Yours should be in the state in which you reside. That provides you the most protection.
Excuse me, we have another session.
Yeah.
Oh,
Well,
great.
thank you, Dr.
Thank you very
Excellent.
much.
Thank you very much.
And I have more cards and things here. Feel free to take.
Don't forget to fill out your evals.